Okay, thank you all for coming back in. Got the walls up now. Yes. So I'd like to introduce to you now Dr. William Young. He's a board-certified neurologist and professor of neurology, director of the inpatient program at the Jefferson Headache Center, and member of the Pharmacy and Therapeutics Committee at Thomas Jefferson University here in Philadelphia. Dr. Young is a fellow of the American Headache Society, American Academy of Neurology, American Neurological Association, and the College of Physicians of Philadelphia. He is the president of the Alliance for Headache Disorders Advocacy, a board member with us here at Miles for Migraine, and he is a graduate of the Palatucci Advocacy Program of the American Academy of Neurology. Dr. Young's publications include many peer-reviewed articles, book chapters, and miscellaneous publications. His special interests include post-traumatic headache, treatment of intractable migraine, migraine stigma, and migraine phenomenology. His topic today is reducing stigma and increasing patient advocacy. Thanks, Dr. Young.
Thank you very much. This has been a great adventure for me, and I'm going to tell you sort of my personal story of how I got into this, and it's meant a lot in my life. So I hope you'll like it. So maybe 10 or 15 years ago, I was presenting an academic paper and standing by my poster, and a member of the department came to me and she said, "I'm glad you do headache. I don't like treating those patients." Then she walked away, and I remember feeling angry and kind of bad and not saying anything. But that memory stuck with me, and I've heard it in many times in many different ways, it just sat there, sort of steeping away, and then a few years later, some of you may have heard of him. Bob Shapiro came up, and he was setting up the Alliance for Headache Disorders Advocacy, and he asked me to be vice president. And he nominated me to be a Palatucci Fellow, which is this program that the Academy of Neurology has, and they sent me to a really nice place, and I worked really hard, and it was very embarrassing, standing up in public and learning things, and it was difficult, but it really changed my life, and I came out seeing myself and what I can do in this world a little bit differently, that really started the whole thing. So, this is the synopsis of my talk here, but, we at Alliance for Headache Disorders Advocacy decided to focus on how little research is being done in migraine and for other headache disorders like cluster headache. Because it was so terrible, because funding for research in headache disorders is so terrible, I had to wonder why. And so, that experience from before sort of, made me postulate that it might have something to do with the stigma of migraine. And then I was, one day I was looking up, doing research on something else, and searching the medical literature, and I saw this paper on measuring stigma in chronic disease, and that was kind of interesting, and I thought it might be important. And then the very next day, an intern who was going to be a neurology resident stopped by, and she said, "I'm going to be a neurology resident. I have a free month, and I want to do research with you." And so I had this paper, and we brought it together, and we ended up producing a paper with Dr. Joanna Kempner, I became the world's expert on the stigma of migraine because of that. As we were doing this, we had a conversation, and somebody asked the question, is migraine a disease? And I thought that might be important. So I actually, did some work, and I wrote a paper about that, and I'll tell you about that. Meanwhile, a participant in this naming study sent me a paper on branding diseases. It was about for industry pharmaceutical marketing, like how do you brand a disease if you want to sell a product? And I thought, well, this is really interesting. Very simple, straightforward, step 1, step 2, step 3, this is how you do it. And I thought, that's great, but we should be doing it. Patients, people who, doctors, scientists should be branding this disease. This is our job. And so I became sort of involved in thinking about that, and I began to see that we needed that it would take an advocacy movement to rebrand this disease as something that is worth doing something about, that's worth funding, that's worth investing in the resources to take care of patients. I think we need to think, what is the brand that migraine ought to have? Or I don't know if Joanna's still here, as she has taught me, that what is the frame? What frame should migraine have? And I don't think that that's an easy question, but I think it's one that if as a community we can come up with an answer and have a more or less single message, even if the brand isn't perfect, it can't be any worse than the one that we have now. So let's get on with it. This is my history. Alliance for Headache Disorders Advocacy. NIH wasn't funding migraine. Maybe it's the stigma. Is migraine a disease? What should we name it? How do we frame it? And now I'm in Miles for Migraine. So this is what I'm going to tell you about. So Joanna showed this slide, and she explained to you that the burden of disease is on the x-axis and the amount of dollars in NIH funding is on the y-axis. And just a little thing for any of you who are mathematically inclined, this is a log-log scale, which means that distance from migraine to schizophrenia, which is about the same burden of illness as migraine, is much greater than it even appears on that scale. So it is really shocking how bad the NIH funding is for migraine. And we ought to be around $241 million, and we're at 20. So it looks like it's halfway there, but it's a tenth, an eighth of the way. A 12th of the way there. Now to the stigma side. So stigma is an established construct in the social sciences that describes an attribute, trait, or disorder that is deeply discredited and may elicit some form of community sanction. And I challenge anybody in this room to say that that does not apply to the disease of migraine. And you can look at the process of stigma. There's an enacted stigma. So somebody says something ignorant, putting down, and it's just a headache or whatever they say, and it's felt or perceived, and you become aware of the stereotype. But gradually over time, and this is the diabolical part of it, that stigma gets incorporated. So it changes us. And there becomes, unfortunately, self-concurrence and internalization. And so the stigma becomes internalized. And then there's a decrement of self-esteem, and there is considerable provable psychological distress that results from this stigma, the enacted stigma, the internalization, and then the psychological distress that results from it. So this is the results of my study. These are the numbers. Is my clinic, the chronic migraine patients, the episodics are at the top, the chronics are in the middle, and we had epilepsy patients from the epilepsy clinic. And for those of you, you may or may not know, but epilepsy is considered the stereotype for the stigma in neurologic disease. And there's been a lot of studies of epilepsy as a stigmatized disease. And you can see that just obviously the stigma in the chronic migraine group is greater than the episodic migraine group and the epilepsy group. Remember, we know that all three are stigmatized, but it's worse for the chronic migraine. We looked at why this might be true, and we looked at certain factors, and it turns out that the ability to work, and work in the social work best predicts the stigma score that you would get, and that the mental quality of life also connected or was correlated with stigma. And when we considered the ability to work and we factored that into all our equations, chronic migraine and epilepsy were equally stigmatized. And the reason that in the gross numbers, chronic migraine was worse than epilepsy because more people had lost their jobs in the chronic migraine group than in the epilepsy group due to their migraine disease. An episodic migraine was a little bit less stigmatized than chronic migraine and epilepsy if you boiled out the disability of the disease. The next chapter is naming migraine. So I decided to ask the question is migraine a disease or a condition? And what's the evidence for them? And maybe we could find a consensus. That discussion is based on on a number of things. But when you name something, there's sort of scientific evidence. What is a disease? And there's also the language is a consensus. So it's really what we decide as a population. We mean when we use the word condition or we use the word disease. And reading the Oxford Dictionary or Webster's, and we read both for this study, didn't help us that much because you could justify any of those names based upon the dictionary definition. Osteoporosis has become a disease. Erectile dysfunction was renamed from impotence, and homosexuality used to be a disease and now it's not. And obesity, there's a debate whether it is a disease or not. I don't think that's been resolved. And then there's the concern of whether one would be accused of disease mongering. Are we trying to amplify this condition for our interest or selfish interests in making this a disease or not? Those were considerations, and we considered illness, disease, disorder, syndrome, condition, and one of the participants put in susceptibility. And what do you call the person with migraine? Are they a migraineur or are they a person with migraine? You might sort of get a hint of what my answers to these questions have been from the way I talk. And what do you call what is not a good idea to call the person who's got migraine? So we put forth a Delphi Panel, which it's not what you see in that picture because it's done on paper. So the idea is that the loud arrogant intimidator can't sway the argument if it's through email or on paper, and you get ideas. And there was patients and social scientists and English professors and neuroscientists and family doctors and headache specialists and internists and a bunch, and we really tried to get a lot of ideas, in the mix and a lot of perspectives, which if I had to do it again, I got to tell you that, getting these people to work together and to listen to one another when there were 15 of them, when you have a Delphi panel, keep it down to like 8, maybe at most 10. Don't make that mistake. It's looking at the discussions we had, because it's all written and you can analyze it later. There's the biomedical evidence. What's for a disease, is there a change in the organ, physiological or structural change? What is the cultural meaning of disease or condition or susceptibility or whatever, and what is the context in which it is? And as an example, I set forth a bunch of vignettes. So at one extreme, you have an 18-year-old woman who dropped out of high school at 16 and lost 30 pounds because she was vomiting every day, and that might be more likely that you'll call that a disease. And there was the person who had a migraine aura and never got a headache and was concerned for a few minutes that something might be, that they might have a brain tumor, and so they saw a doctor. And it's a curiosity at this point. It's not a, and I personally would be hard pressed to call somebody who has 1 or 2 auras in their life somebody who has a disease. So what is the context in which you are used? And as I hinted at, we didn't agree on too much, but we agreed that one should say migraine and not migraine headache. Unless you're only talking about the pain and nothing else that migraine does to you, which is so very much. And that any words that have a psychiatric flavor should be avoided. We also agreed that sufferer should not be used often. A person, and this is how it's a Buddhist, a pain may be inevitable, but suffering is a good principle to have. And that maybe it's really, migraine is such, is a disease of such scope, so many different types of symptoms and levels of severity, that maybe it is actually okay to have some choices to use within the English language of what we're going to call the migraine. As sort of as an overall sense, there was not consensus. A plurality preferred disease over any of the other choices. And as between migraineur and person with migraine, they were basically tied. I think person with migraine had a little bit a numerical superiority over migraineur. And just to make the argument, or why one would argue against migraineur, it's like saying schizophrenic or epileptic. It bathes, it marinates the person with the condition in their disease. So it's better, I think, to think of someone as, a person who has epilepsy, but that's not who they are. And migraineur is sort of trends towards, calling somebody that. Now, it's to my ear, I was one of the later people to get, seduced over to the person with migraine. It's a little bit more effortful to say that. Migraineur has this nice, like, Frenchy sound that sounds sophisticated. But I think fundamentally, for me, that's what I came to think. So here is, what I think. These are that this is not what the group, had a consensus about. This is after the whole thing is over. I wrote the paper. I was the coordinator, and I didn't have a vote. But I couldn't help but make an opinion. I think, if it's severe, you have a disease. If it's not so severe, or you're talking about rats or something else, that you can use the condition. I think that you should say migraine and not migraines. Migraines stresses the attack. Migraine stresses the overall condition, the disease. I think you're not a sufferer, you're a person with migraine, and we don't like medication overuse. We like rebound headache. So that comes to the reframing. Framing is that first feeling or thought about a condition that people have, that gut feeling, and diseases can have that, but they can be reframed. And I spoke a little bit about that before. Dr. Kempner spoke about this. Influences on framing include race, class, gender, behavioral causes of illness sort of have a negative effect on it, and causal attributions can affect the health policy opinion. So she gave the example, which is the classic one of, there's 3 times more deaths from lung cancer than from breast cancer, but there's 3 times more money spent on breast cancer than lung cancer, as an example where causal attribution have an effect on disease framing and health policy. So in migraine, I think that there are frames that don't work, that don't help us as a community. Migraine is very common. I think that undermines the seriousness of this disease. If migraine is so terrible, and there are 38 million people with it, then our population should be inundated, and I don't see that. Dr. Kempner said, saying something arises from the brain is a lateral move. It's not. It doesn't help to stress that in terms of reframing the disease and getting a better position. I think it helps the person who has it, because it's true, and it helps you to understand what's going on, but I don't think it helps us in terms of getting NIH funding, in terms of getting better resources from insurance companies and others. A pill will fix it, that doesn't help. And there are people, who stress the increased risk of stroke if you have migraine with aura and other parts of this. I don't think that sort of can get. Those are statistical arguments. You don't go around knowing somebody who had a migraine stroke, or that their heart attack had a 5% chance that it was caused because they had their migraine or whatever. That doesn't help us. It doesn't ring true. A frame has to be something that you jump to immediately in what you think about the disease. I think that migraine is many things, but and what we emphasize out of this very complex condition really matters. What we think of, and what that says is what we think about ourselves, and that matters even more. This is, I wrote this for another group, but this is what I think. Migraine patients are never honored for their injury from migraine and their struggle in coping with it. We need to honor the struggle of those who push through it. We need to appreciate their strength and creativity. We need to show that it is unacceptable to stigmatize and bully those who demonstrate strength, perseverance, dignity, and sometimes wit as they manage their complex and mysterious condition, eking out the best life that they can for themselves and for those they care for. So that brings me to MOS for migraine. I think it really changes the frame. It only changes, though, if people get out there. I've had this discussion, and it kind of disturbs me, because you should know that there have been headache doctors who've tried to get patients out there, and they haven't been successful at getting patients to participate in activities and do things. and they say migraine patients won't do anything for themselves. It's the biology of their disease. Their disease makes them want to stay away from things and not get out there. Please help me to prove them wrong. We'll raise some money along the way for research, and we'll make new headache doctors. But more importantly, we will reduce the stigma, because the one thing that the study of stigma has shown is that every advocacy movement that has been successful because people get out and stand up for the disease. From AIDS, some of you may be old enough, like me, to have, been adults when there was this shocking transformation of the view of in the frame of AIDS to breast cancer to autism, and we need that. We really need that for migraine. But then everything is easier said than done, except for talking. That's about the same. Okay, thank you. I'm sure I went over. I apologize.
We don't have any questions. So we don't have any questions. So, you have a question. Okay, just what's your question? Just say it, because.
Just a request, could you go back 2 slides? There, I noticed a couple people were going to snap that one snap.
When you say migraine with aura, I've been reading that like yawning is now considered an aura. Is it? So
No.
It's like a pro?
Migraine, yawning is a prodrome.
Okay, so you're only talking aura like the visual.
Yeah, I mean, some people often see a specialist because they've had their first aura and they don't know what it means. And it could be that it doesn't even attach to a serious pain or migraine or any other symptoms. They just have, for some people, that's their migraine, is a 20-minute aura, and they have a couple in their life. And honestly, compared to what my patients go through, they have nothing.
So everything else is just the prodrome and everything.
Well,
The
yeah,
visual is just the aura.
for most people, yeah.